welcome to Neurosurgery Basics. Today's topic is going to be on neck pain and evidence-based management. Just a brief introduction about neck pain. About 80% or more individuals will experience neck pain and associated disorders during their lifetime. Now the thing with neck pain, just like with back pain, most of it is quite non-specific and so can be difficult to treat. Only about 1 to 2% have serious pathologies. Now, how do we evaluate somebody who has come to us with neck pain? So the first thing obviously is to perform a history and examination and rule out these major structural or other pathologies. After that, you can actually classify neck pain from grade 1 to grade 4 NAD, where NAD stands for neck pain and associated disorders. The term NAD and its classification has been developed by the Bone and Joint Decade Task Force on Neck Pain and its associated disorders. So what is this classification? The classification divides NAD into 1, 2, 3 and 4 grades. Okay, and 4 is the worst and 1 is the best. So in grade 1, there are no signs or symptoms just of major structural pathology, and there's no or only minor interference with the activities of daily living. In grade 2, there are again no signs or symptoms of major structural pathology, but there is some interference, which is major, with activities of daily living. In grade 3, there again are no signs or symptoms of major structural pathology, but you do have the presence of neurologic signs, such as decreased deep tendon reflexes, weakness, or sensory deficits. And grade 4 is when you have the signs or symptoms of a major structural pathology. So that's NAD grades 1, 2, 3, and 4. 1, you don't really have any significant problems. 2, you're affecting the activities of daily living. In 3, you have neurologic signs, and in 4, you have signs and symptoms of major structural pathologies. Now, as we had discussed with back pain, we also have particular red flags that might point to some particular conditions, even with neck pain. And these red flags would require an appropriate referral to a particular specialist. So for example, if you find anything positive on the Canadian C-spine rule, it mostly indicates you might have a fracture or a dislocation, and the patient should be referred to a spine surgeon. If there's a history of cancer, unexplained weight loss, nocturnal pain can be present either in cancer or inflammation, or if the age is more than 50 and the patient has new onset pain, we have to suspect it might be cancer and refer them to an oncologist. If the patient has fever, IV drug use history, or any recent infection, they might have a vertebral infection and they should go to a spine surgeon. If there's any history of osteoporosis, if they've ever used corticosteroids, or they are old, they might have an osteoporotic fracture and they should be evaluated for osteoporosis. There are clear signs which point towards myelopathy as well, like sometimes a painful and stiff neck might indicate the presence of myelopathy, arm pain and weakness, sensory changes in the lower extremity, motor weakness and atrophy, hyperreflexia, and a spastic gait can all indicate myelopathy and require referral to a neurologist or a neurosurgeon. A sudden and intense onset of headache or neck pain might indicate a vascular problem leading to carotid or vertebral artery dissection, which needs evaluation. A sudden and intense onset of headache might also indicate a brain hemorrhage or subarachnoid hemorrhage, again requiring evaluation. And particularly morning stiffness and swelling in multiple joints can indicate inflammatory arthritis, which should be referred to a rheumatologist. Now, apart from the red flags indicating particular specific disorders, you can also have neck pain presenting with radicular syndrome, the same way that we had it for back pain. Now, radicular syndrome can present in 3 different types. There could be radicular pain, where the arm or shoulder pain will typically be worse than the neck pain. The neck pain will be sharp, lancinating, or a deep ache, and it will increase with cough, sneezing, or straining. And the neck pain will be unilateral and situated around a particular dermatome. For example, for C5 will be around the shoulder, it'll be around the arm for C6 and C7, and around the fingers for C7, C8, and T1. Also, you can do a Sperling test for cervical radiculopathy and radicular pain. What you need to do in this test is hold the patient's neck, extend it, and then flex it laterally on the side of the pain. Along with that, put some downward pressure on top of the head. If this triggers radicular pain, it indicates that there is a narrowing of the neural foramina on that side. Radicular syndrome can also present with radiculopathy, which may or may not be present with radicular pain. Now in radiculopathy, rather than pain, they'll complain of numbness or paresthesias, which will actually typically happen in the distal dermatomes. And they could also have weakness or loss of function, like a weakness of the hand grip. On examination, you have classic signs of radiculopathy. You can have diminished light touch or pinprick in the dermatomal distribution and paresthesias. You could have myotomal weakness, and you could have reduced deep tendon reflexes. A patient might also present another way with neurological syndromes with myelopathy. Now, in that case, how would a patient present? They could present with upper extremity symptoms or lower extremity symptoms. Upper extremity symptoms in myelopathy are usually hand clumsiness, inability to perform fine motor tasks like buttoning a shirt, and lower extremity symptoms are usually frequently tripping while walking on uneven surfaces and a stiff gait. So the classic symptoms that a patient with myelopathy presents with. On examination, you have a combination of both lower motor neuron and upper motor neuron involvement, depending on the level of the myelopathy. So in sensory examination, you get diminished light touch or pinprick sensation below the level of involvement, altered joint position and vibration sense, and Romberg's test will be positive. There will be spastic weakness, predominantly involving the distal muscles, exaggerated reflexes below the level of involvement. Babinski sign will be positive, and sometimes you might even get a Lermit sign, with an electric shock-like sensation which radiates down the spine and even into the extremity sometimes whenever you flex the neck. Okay, now how do we evaluate somebody who has come to us with neck pain? So as we discussed, when a patient presents to us with neck pain, the first thing we'll do is a focused history and physical examination. Okay, and the basic idea over there is to find out if somebody has red flags which indicate a specific spine pathology, which according to the NAD classification would be NAD grade 4. If there are these red flags, then the patient has to be evaluated for those particular conditions and referred appropriately. Now, if somebody is coming to us without these red flags, they could either be NAD 1, 2, or 3, depending on their features. If there is no interference with activities of daily living, it's NAD 1. There's a major interference with activities of daily living, that's NAD 2. Or there's features of radiculopathy like decreased reflexes, weakness or sensory loss, then it's NAD 3. Now, how do we treat patients who are presenting to us with the more minor NAD, that is NAD 1 and NAD 2? Okay, we'll discuss the care pathway for NAD 3 later. So in NAD 1 or 2, we should have already established with history and examination there's no specific spinal pathology and there's no radicular syndrome. Right? Now, NAD 1 or NAD 2 could either be of a recent onset, that is less than 3 months, or it could be persistent, that is more than 3 months. I want to be very clear here, okay, and this is evidence-based, and it is very important to not offer two things for somebody who has NAD1 and NAD2. That's basically any non-specific neck pain presenting without radiculopathy, without any red flags. Do not perform imaging for them and do not offer them a cervical collar. Okay, now if somebody with NAD 1 or 2 has a recent onset of neck pain, that is, it has lasted for less than 3 months, what you can offer is structured education, and we will discuss what that is next. Also, reassurance, tell them that it is a non-specific disorder that is going to resolve by itself in some time. And along with structured education and reassurance, you should also offer one of the following. Either it could be unsupervised neck range of motion exercises, multimodal care, that's a combination of manipulation or mobilization and unsupervised exercise, or you could offer them a short duration of NSAIDs for 5 to 7 days. If you notice here, the medication or the NSAIDs are the last option here. So everybody has to be offered structured education and reassurance, and you can offer them one of these 3 options. NSAID is always not required for these patients. Now, if it is persisted for more than 3 months and it is still NAD 1 or 2, again, still do not perform imaging and do not offer a cervical collar. Again, offer them structured education and reassurance. And now you can combine them with five different options. You have to offer one of these options. It could be supervised combined exercises. It could be yoga. It could be multimodal care. Again, that could include a combination of neck range of motion exercises and manipulation or mobilization, if this has already not been done in the first 3 months of care. You could also offer a clinical massage, not the same as the relaxation massage, which should not be offered. And again, they could be offered again a short duration of NSAIDs for 5 to 7 days. If you notice again, even if it is persistent for more than 3 months, NSAIDs are only 1 out of 5 options that should be offered along with structured education and reassurance. Okay, once you start them on this therapy, you should ask them to follow up after a certain period of time to check if the symptoms have resolved. If it's a recent onset, you can ask them to follow up within a week. If it's persistent, you can ask them to follow up within 6 weeks. Okay, now if they have not improved on their follow-up, it is important to assess for something known as poor prognostic factors. Now these poor prognostic factors also we will discuss next, but these are factors that can actually decrease the chance of improvement in these patients. So you have to go in, basically check for these poor prognostic factors. If some of them are modifiable, address the poor prognostic factors and take care of that. Now, even after that, if the patient with recent onset NAD 1 and 2 has an incomplete recovery, then you would go and initiate the persistent protocol. That's the more than 3 months protocol on this side. But if they have progressed to grade 3, then you would initiate the grade 3 pathway. And if any time they develop a serious pathology, then you refer them to the spine surgeon. On the other hand, in the persistent pathway, if there is incomplete recovery, then you directly have to refer them to the spine surgeon to evaluate for surgery. If they progress to grade 3, we would initiate NAD 3 care pathways, and if they've developed a serious pathology, again, they can be referred to a spine surgeon for further evaluation. Now, what are these poor prognostic factors that we were discussing? Right? So these are basically factors that lead to a delayed recovery in patients with neck pain. So one would be severity. So NAD grade 2 and grade 3 will recover slower than NAD grade 1 will. So the more severe the pain, the slower it will recover. Patients with an older age will recover more slowly. Patients with prior neck pain, high levels of initial pain and high levels of initial disability will also recover slowly. And sometimes important psychological factors following a trauma which has led to the neck pain can also lead to poor prognosis. So this could be either because they just have a poor expectation of recovery, like I will not recover well or I will not recover quickly. They could have symptoms of acute stress disorder which manifests within 4 weeks of injury. They could have symptoms of PTSD lasting for at least 4 weeks. They could have a depressed mood or feelings of depression or about the pain, which can lead to a poor prognostic factor leading to delayed recovery. They could have some anxiety or fear about the pain, high levels of frustration or anger about the pain. Their coping mechanisms could just be poor and they just be passive coping rather than active coping. And they could also have a fear of moving because of the neck pain, also known as kinesiophobia. And they could be avoiding activities due to the fear of pain. So it is important to assess those poor prognostic factors, and whatever is modifiable, mostly with psychotherapy, can be modified, and that really helps the patients who have prolonged pain. Another thing we should provide to all patients with NAD 1 and 2 is structural education. So we need to educate and reassure patients about the benign and self-limited nature of the typical course of NAD 1 to 3, but not 4. And advise patients to remain active. Emphasize that the treatment should be active rather than passive. Okay, they have to be involved in their own treatment, and there has to be a lot of movement and activity that needs to happen for their pain to go away. Patients with worsening or new physical signs or symptoms or psychological signs or symptoms should be referred for further evaluation. Explain to the patient that the natural history for NAD I to III is generally favorable and most will usually improve within 4 to 6 weeks. Emphasize that they should remain active and maintain function and reduce maladaptive coping strategies. They should reduce the belief that activity is unsafe and should be avoided, that is known as fear avoidance. They should reduce the belief that low back pain will never improve, known as catastrophizing. And you should reassure patients that course is benign and self-limited. Another thing that you can tell them to do by themselves is that for symptom relief, they can actually go ahead and use superficial heat like a heating pad. Okay, so I would like to discuss what are the recommended interventions that you can offer for patients with NAD I to II. Okay, so as we discussed, we want to offer structured patient education along with reassurance with either one of these three things. So within structured patient education, we want to offer, as we discussed in the previous slide, information about nature or management and the course of NAD. Patients should participate in decision-making process. And how do we do this education? Either a video or a booklet can be used for this. Now, you can combine this with reassurance and either exercise, multimodal care, or medication. In exercise, you have to ask them to do neck range of motion exercises 5 to 10 times, that's 5 to 10 repetitions, without resistance. There should not be a resistance training. It should be done without any resistance 6 to 8 times a day. What exercises can they do? They can do neck retraction, extension, flexion, rotation, lateral bending, and scapular retraction. They should be done daily and at home. They can also have a little bit more supervised therapy under multimodal care. That's a maximum of 6 sessions done over 8 weeks, where you do the ROM exercises again, but along with supervised therapy like manual therapy, which could involve manipulation or mobilization of the cervical and or thoracic spine. That is obviously done by a physiotherapist who's trained. You can also give them medication. Most likely what we'd give them is NSAIDs, as we discussed, for 5 to 7 days only. For recent onset disease, you can also give them a short course of muscle relaxants like cyclobenzaprine, but this does have potential side effects and you should closely monitor these patients. In recent onset NAD I to II, we do not have any evidence for the use of paracetamol. Now, what about patients who have chronic NAD I to II? So again, they would require structured patient education and reassurance, but those two can be combined with any one of these 5 different modalities. So these are a little bit different for the chronic patients. For chronic patients, you have to offer them exercise, which is not just unsupervised and at home. It needs to be supervised combined exercise, range of motion with strengthening. So here, resistance training will come in play, which is limited to a maximum of 2 sessions happening per week for a total of 12 weeks. You can also offer them yoga of maximum 9 sessions over 9 weeks done by a certified yoga teacher. You can offer multimodal care, which is maximum of 6 sessions happening over 8 weeks, similar to what we do for recent onset NAD, which is again ROM exercises and manipulation or mobilization. They should only be considered if it was not done in the first 3 months of care. If patient did improve but continues to still have pain even after 1 course, you can offer them a second course. Apart from that, you can also offer clinical massage, that is soft tissue therapy. 10 sessions can be offered over 10 weeks, but this only provides short-term benefits and we should not offer them relaxation massages. And lastly, we can also offer them medication. If you're offering medication, NSAIDs will be the first line, again used for a short duration only. If the patients cannot receive NSAIDs, you can give them acetaminophen for chronic NAD I to II. If these don't work, then second line additions could be tricyclic antidepressants or SNRIs. Opioids can be used in patients with chronic pain, but should be used with caution, with concern for dependence. Now, how will we treat somebody who comes with NAD III? Remember, NAD III is basically neck pain associated with features of radiculopathy. Okay, now if somebody has come with NAD III, again we will classify them into a recent onset or a persistent NAD. We do not offer surgery for recent onset NAD. We offer surgery for persistent NAD, which has lasted for more than 3 months. Right? So if somebody comes with a recent onset NAD, again, even though they have features of radiculopathy. If it is recent onset NAD grade 3 lasting for less than 3 months, you do not need to perform imaging and do not need to offer them a cervical collar. Again, offer structured education and reassurance, supervised graded neck strengthening exercises, and a short duration of NSAIDs. If they do not improve after 1 week, then they can be referred for evaluation by a spine surgeon. For patients with persistent NAD grade 3, which has lasted for more than 3 months, they should directly be referred for evaluation for surgery. Okay, now what are the different medications that we can give to patients who have non-specific neck pain? So that depends on whether the neck pain is acute or if it is chronic. If it is acute, that is it's less than 3 months, the first line would be NSAIDs like diclofenac or ibuprofen, and you should always monitor side effects with NSAIDs. Second line, you can, if it's severe, use tramadol, and you can use cyclobenzaprine. Both have side effects, but remember there's always addiction potential with tramadol. All drugs should not be used for beyond 7 days. For chronic non-specific neck pain, on the other hand, you can use NSAIDs and paracetamol as first line. If that does not work, then you should switch on to tricyclic antidepressants like duloxetine, pregabalin, or gabapentin. But remember, gabapentinoids have a lot of side effects, and sometimes it is difficult for patients to tolerate these drugs. It has become rampant to use these drugs for patients with neck pain and back pain, but you really need to figure out if your patient falls into a particular category that may require these drugs. And the evidence for gabapentinoids is really not that strong yet. You can also offer them tramadol or low-dose opioids. Okay, so out of all the therapies that exist for neck pain, this is the current evidence basis for these therapies. There's no strong for any therapy, but we do have some interventions that fall into moderate category of evidence and weak category of evidence. There's only one intervention that is absolutely contraindicated with evidence, and that is bed rest. Bed rest should not be offered to anybody with neck pain. This is for patients with non-specific neck pain. We do not have clear evidence to decide whether these interventions are good or bad. Thermotherapy, manual therapy, traction, electrotherapy, orthoses, acupuncture, and imaging. We just do not have conclusive evidence about them. What therapies have a moderate basis of evidence are topical medications, including NSAIDs, manual therapy combined with other treatment, exercise programs of therapy, and exercise therapy combined with other treatment. What therapies or interventions have a weak basis of evidence for their usage include reassurance, advice and education, remaining active, encouraging physical exercise, analgesics, paracetamol, NSAIDs, and opioids. Right, so that is all for today's lecture, and thank you so much for attending.